We were doing rheumatology, and we discussed some diseases which were affecting joints as well as other system of the body, such as SLE, rheumatoid arthritis, Sjogren syndrome, and scleroderma. Today we'll discuss some more autoimmune diseases. So the first topic for today is myopathies. What are myopathies? Myopathies are basically skeletal muscles disorders. The features of myopathies that will be common to all the causes of myopathies, they include symmetrical muscle weakness. Proximal muscle weakness will be more than distal muscle weakness. How proximal muscle weakness will manifests, or how proximal muscle weakness will present to us. Proximal muscle weakness of lower limb will result in difficulty in rising from chair, getting out of bath, and upper limb proximal muscle weakness will result in difficulty in combing hair. So these are some features. If these features are given in the question stem, then you will suspect proximal muscle myopathy. Usually in myopathy, sensation and reflexes are normal and there are no fasciculations. Because myopathies are basically due to problems in the skeletal muscles. So that's why sensation and reflexes are normal and there are no fasciculations. While myopathies that are due to some nerve lesions such as lower motor neuron lesions or problem in the nerves such as myasthenia gravis and Lambert-Eaton syndrome. In these disorders, nerves are affected. So that's why myopathies that are due to problem in the nerves, they will not have normal reflexes or sensation. Now, some causes of myopathies. Inflammatory causes of myopathies include polymyositis. Inherited causes of myopathies, they include Duchenne and Baker, muscular dystrophy, and myotonic dystrophy. Cushing and thyrotoxicosis and alcohol can also result in myopathies. And add one other cause of proximal muscle myopathy to these causes, and that is vitamin D deficiency. Remember that vitamin D deficiency can also present with features of proximal muscle weakness, such as rising from chair, combing hair, getting out of bath, or standing up from a sitting position. In this chapter, we will discuss only the inflammatory causes of myopathies, inherited causes such as Duchenne and Becker muscular dystrophy and myotonic dystrophy. We will discuss in genetic disease chapter, and endocrine causes. The main presentation of endocrine causes such as Cushing syndrome and thyrotoxicosis. They also have some other clinical features other than myopathies. So the first autoimmune cause of myopathy, proximal muscle myopathy, is polymyositis. Myositis means inflammation of the muscle fiber. Symmetrical and diffuse muscle weakness involving the proximal muscles of neck, shoulder, trunk, hip, and thighs. So it is a diffuse muscle weakness which involve almost all the proximal muscles in the body, such as neck, shoulder, trunk, hip, and thighs. Lower limb is affected first and then upper limb is affected. So the common problems that we already discussed, that the patient will have a difficulty in rising from a seated position, a difficulty in combing her hair, getting out of bath, lifting objects and climbing stairs. So this is how proximal muscle weakness will manifest. On investigation, because polymyositis result in the destruction of the skeletal muscle fiber. So when a skeletal muscle fiber is destroyed, it will release creatine kinase. We discuss in rhabdomyolysis. Rhabdomyolysis is due to prolonged immobility or due to trauma or due to muscle injury. That creatine kinase is also increased in the rhabdomyolysis. In polymyositis, it is also increased, but the cause of this increase is autoimmune cause. So on initial investigation, increase creatine kinase. And the other investigation, they include anti-Jo1 antibodies, LDH and aldolase. Electromyography is also done, and muscle biopsy is the definitive test. So initial investigation, they include serum creatine kinase, anti-Jo1 antibodies, LDH and aldolase, serum creatine kinase because a dying skeletal muscle will release creatine kinase as well as LDH and aldolase. So these three enzymes, they will be increased. Anti-Jo1 antibodies, they are specific for polymyositis, and the diagnosis will be confirmed on muscle biopsy. Because it is an autoimmune condition, so the treatment is steroids. So proximal muscle weakness with increased creatine kinase, your diagnosis will be polymyositis. Now the second cause of proximal muscle weakness is polymyalgia rheumatica. Polymyositis is basically a muscle weakness, while polymyalgia rheumatica, the main complaint will be muscle stiffness and pain, bilateral pain and morning stiffness of shoulder, neck, and pelvic girdle. Due to stiffness or pain in the proximal muscles, the patient will have difficulty in getting out of bed, raising the arm to brush the hair. So the clinical presentation is almost similar. The difference in clinical presentation between polymyositis and polymyalgia rheumatica is that in polymyalgia rheumatica, morning stiffness is more than muscle weakness. So in polymyalgia rheumatica, the muscle is more stiff and not weak. Due to this stiffness of the muscles and pain, the patient has presentation similar to proximal muscle weakness. That is getting out of bed, climbing the chair, climbing the stairs, and brushing the hair, etc. Now, there's one important association with polymyalgia rheumatica, that is giant cell arteritis. So polymyalgia rheumatica is associated with giant cell arteritis, and it is common in people who are above 50 years of age. ESR will be raised like in polymyositis. Similar to polymyositis, ESR and CRP, they will be raised. But remember that in polymyalgia rheumatica, there is inflammation of the muscles, but not a destruction or necrosis of the muscle fiber. So creatinine level will be normal. Creatinine kinase will be normal. In polymyositis, there's destruction of the skeletal muscles. So that's why creatinine kinase is raised in polymyositis. While in polymyalgia rheumatica, there's no destruction of the skeletal muscles. So that's why creatinine kinase is normal. So someone with the features of proximal muscle weakness and normal creatinine kinase, your diagnosis will be polymyalgia rheumatica. Someone with proximal muscle weakness and raised creatinine kinase, your diagnosis will be polymyositis. So proximal muscle weakness with raised creatinine kinase, polymyositis. Proximal muscle weakness with normal creatinine kinase, polymyalgia rheumatica. So this is one way by which you can differentiate between these two conditions. The second way is on the basis of clinical presentation. If the person is complaining of stiffness of the muscles, then it is polymyalgia rheumatica. And if he's complaining muscle weakness, then it is polymyositis. Now there's a third difference between these two, and that is polymyalgia rheumatica is associated with giant cell arteritis. Giant cell arteritis is basically, as its name indicates, it is arteritis. It is an inflammation of an artery, such as temporal artery and its branches. So giant cell arteritis mainly affect temporal artery and its branches. So if someone present to you with proximal muscle weakness and he has features of temporal arteritis such as unilateral headache and painful jaw, especially on chewing, then your diagnosis, the most likely diagnosis will be polymyalgia rheumatica. So this association is important to remember, that polymyalgia rheumatica is associated with giant cell arteritis. And the branches of giant cell arteritis mainly affect the temporal artery, and the branches of temporal artery, they supplies the area around the jaw and forehead. So the person with giant cell arteritis will complain of unilateral headache and painful jaw, especially on chewing. So if proximal muscle weakness is associated with these features, then your diagnosis will be polymyalgia rheumatica. The treatment in both the cases, in polymyositis and in polymyalgia rheumatica, in both of them, the treatment is steroids. The initial investigation in both of them is ESR. ESR will be raised in both of them. And another initial investigation can be creatinine kinase. Creatinine kinase will be normal in polymyalgia rheumatica and it will be raised in polymyositis. Polymyalgia rheumatica presents with aching and stiffness, while polymyositis present as proximal muscle weakness. So in short, in myositis, weakness is more than pain and creatinine kinase is raised. And polymyalgia, as its name indicates, it's myalgia. So pain is more than the weakness and CK will be normal. So temporal arteritis or giant cell arteritis that usually occur in association with polymyalgia rheumatica or even it can occur without polymyalgia rheumatica. So what are the features of temporal arteritis or giant cell arteritis? Temporal arteritis is basically a large vessel vasculitis, and the vessel that is affected in temporal arteritis is, or giant cell arteritis, is temporal artery. It is common in people who are above 50. Usually the onset is rapid because the temporal artery supplies the forehead, it supplies the branches to ophthalmic artery and central retinal artery. So there will be eye signs as well. And some of its branches supply the blood to the jaw area. So there will be jaw claudication or pain on chewing. And because there is inflammation in the temporal artery, so there will be scalp tenderness. So a patient will present to you with unilateral headache and visual disturbances. Remember that migraine can also present with unilateral headache and visual disturbances, and cluster headache can also present with unilateral headache and visual disturbances. But in cluster headache, there is no jaw claudication or scalp tenderness. So these are two differentiating points on the basis of which you can differentiate it from cluster headache or migraine. And the other differentiating feature is that because it's an autoimmune condition, so ESR will be raised in temporal arteritis or giant cell arteritis. And the second difference between these two is that temporal arteritis is associated with polymyalgia rheumatica. So in short, the presentation will be headache, scalp tenderness. Scalp tenderness is an important feature that indicate inflammation of the blood vessels that supplies the scalp. Scalp tenderness can also manifest as pain during combing. And as I told you that a branch of temporal artery also supplies the retina. So due to inflammation in that branch, the patient can suffer from a visual field loss as well. The initial investigation.
Sorry,
Yes.
one question is about myasthenia gravis. How do we differentiate in this? Like, for example, the patient has almost the same features of proximal muscle weakness. So, how will we differentiate with myasthenia gravis?
First of all, tell me what is the common presentation of myasthenia gravis?
As the patient, they has weakness in the proximal muscles and unable to. I mean, it's like from
Myasthenia
the
gravis.
top to the. It goes
Yes,
from
yes.
top to the upper to the lower limbs. So yeah, and
So upper
also
limbs are affected first, or upper body is affected first. So in patient with myasthenia gravis, first of all, the presentation will be muscle fatigue, and muscle fatigue along
right,
with D symptoms.
right,
What are D symptoms? Drooping of eyelids, dysphagia, dysphonia. So patient with muscle fatigue and D symptoms. This
right.
is the difference on the basis of history. Now,
Mm-hmm.
we discussed in the beginning that in myopathies, in
These breakthrough
myopathies,
muscles, yeah.
sensation and reflexes are normal and no fasciculations are seen. So can you tell me, are the reflexes normal in myasthenia gravis?
They are absent. I think they are absent. Sorry.
Yes,
The reflexes are absent. Yeah,
diminished,
yeah,
diminished
damage.
reflexes.
Right.
While in case of Lambert-Eaton syndrome, that is also has a similar presentation like myasthenia gravis.
Mm-hmm. So the reflexes
Problems
are
are affected first in Lambert-Eaton syndrome. And in Lambert-Eaton syndrome, you know that reflexes are absent initially, but they can be elicited by a repetitive stimulation.
yeah.
And in Lambert-Eaton syndrome, the weakness is worse during at the morning, and it improves with the activity. While in myasthenia gravis, the weakness or muscle fatigue is worse in the evening because all the acetylcholine is consumed. So that's why the weakness in myasthenia gravis, it gets worse with activity or with with the passage of time.
Right. Okay. Thank you.
While the proximal muscle weakness, that is due to vitamin D deficiency, calcium and phosphate will be low in vitamin D deficiency, and ALP will be high.
Right.
So this is how you can differentiate between different causes of proximal myopathy. So there is no such feature as these myopathies, polymyositis and polymyalgia rheumatica. They have no association with the activity.
Okay, that's fine.
Myasthenia gravis, because there is uh, destruction of the
Acetylcholine.
acetylcholine receptor, and acetylcholine is consumed with the activity. So that's why myasthenia gravis gets worse with activity. And Lambert-Eaton syndrome, it gets better with activity because in Lambert-Eaton syndrome, there are antibodies against the calcium
Right.
channels that are present in the nerve terminals. So the calcium accumulate gradually with muscle activity. That's why uh, the weakness improves with activity in Lambert-Eaton syndrome.
Okay, yeah, yeah. Okay, that's fine. Thank you.
So presenting features, reflexes, and association with activity. These are the 3 points on the basis of which you can differentiate between these causes of proximal muscle weakness. So we were discussing temporal arteritis, which is an inflammation of temporal artery and its branches. Anterior temporal artery, zygomatic, and transverse facial artery. You do not need to remember the name of these arteries. Just remember that that one branch of the temporal artery also supplies the retina. So the patient with giant cell arthritis, they can develop blindness. So that's why if there are visual symptoms such as visual field loss, then you need to do an emergency referral, same day referral to an ophthalmologist. So the initial investigation in case of giant cell arteritis is ESR. ESR will be raised because it is an autoimmune and inflammatory condition like polymyositis and polymyalgia rheumatica. So ESR is raised. CRP may also be elevated. The confirmatory test or the diagnostic test or the most appropriate test is temporal artery biopsy, which will show skip lesions. Some of the regions of the artery will be affected and some will have giant cells inflammation. Giant cells are basically enlarged macrophages. So the diagnosis of temporal artery biopsy will be confirmed on, temporal arteritis will be confirmed on biopsy. The treatment, as it is an autoimmune condition, again, the treatment is high dose prednisolone. Treatment for polymyositis and polymyalgia rheumatica were also prednisolone. And because it is a vasculitis and vasculitis can lead to thrombosis, so that's why we need to add low dose aspirin as well. to prevent thrombosis. Kawasaki disease, that is a medium vessel vasculitis that usually occur in children less than 5 years of age. In Kawasaki disease, we use high dose of aspirin, again to prevent thrombosis and to avoid coronary artery aneurysm. And because the person is receiving high dose prednisolone, person with temporal arteritis is receiving high dose prednisolone, and one of the side effects of the prednisolone is that it can cause osteopenia and osteoporosis. So to prevent osteoporosis due to steroids, we need to give bisphosphonates along with high dose prednisolone and low dose aspirin. So if in the exam a patient present to you with features of giant cell arthritis and he is on high dose prednisolone and low dose aspirin, and they ask you about which other medication can be added to the management of this patient, you can select bisphosphonates. Another thing that you need to remember in association with giant cell arthritis, that urgent ophthalmology review. Patient with visual symptoms should be seen the same day by an ophthalmologist because visual damage is often irreversible. So blindness is a feared complication in temporal arthritis. Key learning point in this topic is that aspirin and prednisolone both can be given, but in these two drugs, prednisolone is more important medication to start acutely. So you will start prednisolone first of all, and then you will add aspirin, and then bisphosphonates can also be given. So let's discuss an example. A 58-year-old man presents with a 4-day history of right-sided headache. So a male who is above 50 presents with a right-sided headache. With blurry vision, he has pain around his jaw claudication that worsen with chewing. His ESR is high. High ESR, all the features are pointing toward temporal arteritis or giant cell arteritis. The treatment is high dose prednisolone, and he was already commenced on prednisolone. The other medication that can help in this case is aspirin to decrease the risk of stroke and visual loss. Another example, 55-year-old female feeling stiffness of neck, shoulder, hips in the morning over the past 2 months. Difficulty to get out of bed and get out of her chair. So stiffness of neck, shoulder, hips. So what is the diagnosis on the basis of the first two lines?
Polymyositis.
Polyrheumatic. Polyrheumatic.
Polymyalgia rheumatica, that's right. Because there is a stiffness of neck, shoulder, and hips, and stiffness is a feature of polymyalgia rheumatica. Polymyositis presents with muscle weakness. A few days ago, she developed pain in her left jaw, especially on chewing, and a headache. Her left scalp is tender. Now we have discussed that giant cell arthritis occur in association with polymyalgia rheumatica. So the diagnosis is polymyalgia rheumatica with associated with temporal arteritis, and the treatment is high dose prednisolone. Initial investigation is ESR, and most appropriate investigation is biopsy, temporal artery biopsy. And the third medication that can be added in the management of patient with giant cell arthritis is bisphosphonates to prevent osteoporosis due to steroids. So this was all about polymyositis, polymyalgia rheumatica, and giant cell arteritis or temporal arteritis, their diagnosis and management. I hope it's clear to everyone. If there's any question, then you people can ask.
So ESR will also be raised in polymyositis, or it's only the feature of polymyalgia rheumatica?
It will be raised in polymyalgia rheumatica, in polymyositis, in giant cell arteritis, in dermatomyositis. All of these are autoimmune conditions or inflammatory conditions. So a
Yeah.
raised ESR may be features of all of these diseases. SLE has a raised ESR. Uh,
Mhm.
Rheumatoid arthritis has a raised ESR. Sjogren's syndrome can have a raised ESR.
Right,
ESR means there is inflammation going on in the body.
right,
These are all are inflammatory conditions. So ESR is a non-specific marker of inflammation.
right. Thank you.
Question.
Yes.
um, how many weeks would you recommend the ESR to be done right from the time the patient developed symptoms?
The ESR can be done right away when the patient present to you.
Okay.
Yes.
Okay. Is there any role for CRP or just ESR?
CRP is an indicative of acute inflammation. It may indicate an acute infection. So CRP can sometimes be raised in these inflammatory condition as well. And one more point about ESR is that ESR can be done to monitor the disease because ESR is a marker of inflammation. So after starting steroids, we can do ESR to see if the inflammation is settling down or not. We discussed yesterday that in the monitoring of SLE, ESR can be used.
Right.
Any more questions?